Good evening, all. Myself, Dr. Kiran Varma, working as Emergency Department HOD, Yashoda Hospital, Malakpet. I would like to take this as an opportunity to invite you all for this Friday webinar connected by Yashoda Hospitals in association with Society for Emergency Medicine of India and by. As you all know that we come up with an interesting topic every Friday. This time also we have an interesting topic to discuss upon. So being emergency physician or emergency resident, so we see wide spectrum of cases. So one among the commonest ED visit is like toxicology cases. So we see a number of cases of toxicology. So each and everything is different. Something like poison, non-poisonous, then herbicides, pesticides, then multi-tablet overdose. So there are many of its kinds. Then some of them are lethal, some of them are less severe. They will not cause any harm to the body. Sometimes it will cause only symptoms like nausea, vomiting, gastric kind of things. Sometimes they affect on kidney, liver, and entire body, and CNS system, something like that. Then if you eat less quantity of toxicological agent, it will cause more damage. In other way, if you some substances like normal kind of toxic substances, if you eat more amount of, quantity is very high also, they cause only less, cause less severity. So it causes, more of like vice versa. It based on the pathophysiology and then chemical toxicity, then our response to the drug, all these things. So one of the commonest toxicological and more lethal poisoning is aluminum phosphide. So to discuss on this particular topic, aluminum phosphide, so I would like to welcome Dr. Rajvi Rajesh, Assistant Professor of SVP Hospital, Ahmedabad. Dr. Rajesh, I welcome you. Please hand over the forum.
Good evening, sir. Good evening, sir. I hope I'm audible clearly and I'm visible as well. First of all, I would like to thank you and for giving this opportunity. So I think let's start with the topic. So today, good evening to all the friends, colleagues, and all the seniors. So today we are going to discuss a very important topic in form of aluminum phosphide poisoning. So the points that we are going to be covering are we'll take the introduction, characteristics, clinical feature, diagnosis, management, and then the recent.
Dr. Rajesh, please unmute your mic. Yes.
Yes, I did unmute. I think the slides are not. Yeah. Are the slides changing?
Naveen sir? Yes.
So the points that we're going to cover are introduction and epidemiology, characteristics, clinical feature, diagnosis, management, and the recent advances and the modalities. Right. So let's begin with introduction. Aluminum phosphide is a very common pesticide that is very cheaply and effective in our country. And the incidence has been rising currently. The suicide rate due to the pesticide poisoning, whether it is accidental, occupational, it has become a global public health problem. And it accounts for 1/3 of the world's suicide rate. And each year, around 3 lakh deaths have been reported due to pesticides. Now, aluminum phosphide again is as I said, very common pesticide which is used as a rodenticide in our country, and it is one of the cause for most common suicidal death in the North India. Recently, as we all know, aluminum phosphide releases a very toxin gas in form of phosphine. So concerns regarding the threat for chemical terrorism has also been put forth. If you look at the statistics, the lower socioeconomic groups, rural areas, and usually there's a male preponderance. So now let's go to the characteristics. Aluminum phosphide is the basic compound is a metallic salt of phosphorus. It is available as a tablet form and also as a powder form. They're available as dark gray tablets, each containing 3 grams of the component, and the ratio is 56% of aluminum phosphide and 44% as carbonate. The typical odor or the smell that we usually encounter is garlicky or a mousy odor, typically stringent odor. So the mechanism of action of sulfose poisoning, as it is commonly named is it's a cellular toxic poison and as well as it's cardiotoxic. Further, if we discuss the fatal period, it is as low as 1 to 4 hours, and the fatal dose. So, by the inhalational route, according to the routes of exposure, if it is an inhalation route, the dose is 400 to 600 ppm. And if you look at the ingestion dose, as less as 1 tablet, 3 gram, which contains 3 gram of the mixture, is also very fatal. Reports have also said that as low as 150 to 500 milligram dose is also lethal. An ingestion of 0.15 to 0.5 gram has also resulted mortality. So as we can see that it's a very lethal high mortality poison, and even a low dose can lead to a deleterious effect. The most common cause of death by aluminum phosphide poisoning is cardiogenic shock. The mortality rate is as high as 30 to 100%. And if we talk about the antidote, there is no specific antidote available for aluminum phosphide poisoning. And that is why this topic becomes, very important and very talked about, because there is a definitive role of aggressive management and initial resuscitation, as we do not have a specific antidote as of now. So, as I said, the various names that have, that are by which aluminum phosphide is known as sulfose, alphose. If you look at the northern side, it is also known as wheat pill, rice pill, and tablets are usually kept in grains for pesticide and used as rodenticide. So as you can see in the picture, this is a picture of a sulfose powder. It's a 56% powder, as I said, and it will contain 44% carbamate. The net content is 10 gram of the aluminum phosphide poisoning. As you can see, there are various recommendations and direction. For example, we don't have to, we have to destroy the empty pouch after use, right? So these are the precautions specifically given is: do not inhale the dust or the gas, open the pouch and use the fumigate immediately, wear full protective measures. So that shows how much lethal and careful we have to be while we use this compound rather. So now let's talk about the mechanism of action. So aluminum phosphide is the active component of the mixture, but as soon as it comes in contact with either the atmospheric moisture or air or even the hydrochloric acid of the stomach, it is going to liberate a highly toxic gas in form of phosphine, pH3, as you can see in the equation. 1 tablet, that is 3 gram of aluminum phosphide, is approximately going to release 1 gram of phosphine. So 3 gram of aluminum phosphide in that 1 tablet is going to release 1 gram of phosphine, which is highly lethal. But the main point is the tablets gradually lose their potency on exposure to atmosphere as they release phosphine gas and leave behind a non-toxic residue in form of aluminum hydroxide. So if the patient has opened the tablet and taken it directly, that is going to lead to very high mortality. But on the other hand, if the tablet has already been exposed to air, it has been kept in a container for a long period of time, so the phosphine gas is going to be liberated in the atmosphere. It will just leave behind a non-toxic residues. So that is a very important part of the history when we take that whether the patient has taken just uncapped freshly exposed tablet, or it was kept or stored in a container by which the phosphine gas might have been released. Again, so after releasing the phosphine gas, it is colorless and odorless in pure form, but due to certain chemicals and substitutes like phosphine, it gives a foul odor, which resembles the typical garlicky, decaying fish or the mousy odor. So after it is exposed to the stomach, if the patient has taken the aluminum phosphide tablet, phosphine gas, after being released, it will be absorbed throughout the gastrointestinal system. So on absorption, it will lead to further systemic toxic effects involving multiple organs, and which will eventually lead to its manifestations of serious cardiac arrhythmias, shock, acidosis, and pulmonary edema. Phosphine is, we routinely, sometimes we send urine for toxicology if you want to detect some compound, but phosphine is excreted in urine as hypophosphite, and that compound is usually not detected in urine. So the urine for toxicology will not, as an investigation, will not be useful in particularly sulfose poison. And the phosphine gas, either if the particle is inhaled or during, after ingestion, when the phosphine gas is exhaled, it can also directly lead to alveolar capillary damage, and which will lead to eventually ARDS and lung injury. So eventually the mechanism of action of phosphine gas or aluminum phosphide is going to be that it is going to inhibit a very important enzyme known as cytochrome oxidase, which is present in the mitochondria. And this inhibition will switch the metabolism of mitochondria to aerobic to anaerobic. From aerobic, it will switch to anaerobic metabolism, which will lead to eventual metabolic acidosis by accumulation of lactic acid. In the major organ systems, myocardial dysfunction and respiratory failure occurs, which leads to hypotension, hypoxemia, and ultimately death. This is the flow chart, makes easy to understand the mechanism of action. As you can see, aluminum phosphide after ingestion or inhalation leads to activation or release of phosphine. The phosphine is going to inhibit G6PD enzyme, which will inhibit glutathione. Now, glutathione is a main antioxidant enzyme, right? So, inhibition of glutathione is going to result in generation of free radicals, free radical oxygen species. Simultaneously, phosphine also affects the mitochondrial ETC chain and the membrane due to the inhibition of cytochrome C oxidase and the resultant switch to anaerobic metabolism. Further, there is inhibition of the catalase enzyme, which is again a protective enzyme against the free radicals, but that is also inhibited by phosphine. So as you can see, all the components leading to anaerobic metabolism and hypoxia and decreased oxygen uptake leads to tissue injury, multisystem failure, and death. This is just to sum up the various mechanisms of toxicity in brief of the phosphine. Failure of cellular respiration, leading to cellular hypoxia, inhibition of cytochrome C oxidase, formation of highly reactive hydroxyl radicals, cellular injury due to lipid peroxidation, decrease in level of catalase, which is an antioxidant enzyme, and the reduction of glutathione concentration in different tissues. All this explains the cellular injury. Again, effect on mitochondria, failure of cellular respiration, inhibition of cytochrome C, formation of ROS, and the cellular injury. Now let's switch to the clinical features. The sign and symptoms will of course depend on whether the route is inhalation or ingestion. And also, as I said, whether the patient has directly taken the tablet and taken it or it was exposed to atmosphere for a long time. So by the inhalation route, the common clinical features that we see are dryness, irritation of the mucosal membrane, headache, dizziness, and easy fatigability. Now the symptoms of ingestion are divided into mild, moderate, and severe. In mild cases, nausea, vomiting, diarrhea, headache, tachycardia are the common clinical features. While in moderate and severe cases, the systemic symptoms of gastrointestinal, cardiovascular, respiratory, and nervous system appear initially, and later on, the patient goes into hepatic and renal failure, and DICA also occurs. So if you look at the system-wise, and if you take a look at the gastrointestinal system, the earliest symptoms after ingestion are abdominal pain, nausea, vomiting, and diarrhea. Cardiovascular system, a very important system that is being affected by the aluminum phosphide is cardiovascular. Hypotension, pericarditis, myocarditis, congestive heart failure. Special emphasis for the arrhythmias and the ECG changes that occur on ingestion of Selfos. As you can see, it is actually a temporal association. Initially, you may feel that within 3 to 6 hours when the patient arrives, on arrival ECG can just show maybe sinus tachycardia. But after few hours, like after maybe 6 to 12 hours, we have seen STT changes, conduction disturbances, and arrhythmias. According to a study also, on Selfos insertion, ventricular tachycardia occurred in 40% of the cases, SVT occurred in 46% of the cases, while ventricular fibrillation also occurred in 23% of the time. So once we get a patient of Selfos poisoning, we should be extra careful. We should look at ECG. Initially, you may perceive as if the initial ECG is just showing tachycardia, but there are very high chances of arrhythmias which will develop later. Respiratory system, respiratory failure, pulmonary edema, and ARDS. Hepatic and renal. Hepatic failure, renal failure, acute tubular necrosis are some of the known systems. Neurological complications and the manifestations are rare, but they can be in form of ataxia, numbness, muscle weakness, convulsion, altered sensorium, paralysis. Right. So these are the miscellaneous clinical features, but they are equally important. For example, metabolic acidosis. Metabolic acidosis, of course, it occurs due to the accumulation of lactic acid, but it is itself a very poor prognostic marker. Hyperglycemia, DIC, a lot of cases have shown bleeding in sulfose poisoning due to DIC, hypomagnesia, intravascular hemolysis, acute adrenocortical insufficiency. All of these are miscellaneous clinical features, but they also require immediate attention. So this flowchart basically is just a pictorial depiction. So as you can see, the cellular respiration failure and lactic acid production, severe lactic acidosis eventually affects all the major system. It will lead to AKI, muscle injury, liver failure, hypoxic ischemic encephalopathy, ARDS, and especially coronary ischemia, which leads to cardiac arrest, arrhythmias, and refractory shock. So the treatment modalities, as we will of course discuss further, are also based on the overall the mechanism of action and the toxicity that it produces on the various organs. So now we come to the diagnosis point. Of course, first is history. History is very important. The patient may sometimes bring the tablets or may bring the packet of sulfose poisoning. Odor, as we have discussed, is mousy, garlic odor. ECG and echo are of prime importance due to the presence of arrhythmias. And it has been also shown in various studies that we have to do repeated serial ECG and echo monitoring to see the cardiac contractility. Electrolytes, ABJ 6 to 8 hourly. ABJ are usually done 6 to 8 hourly to see the level of metabolic acidosis, to check for base deficit, to check for bicarb level. Chest X-ray and Riles tube. Riles tube, we have to insert Riles tube in sulfose poisoning for lavage decontamination also, and also to take the routine RT sample that we take for medical legal purposes. One of the most important for diagnosis is do not delay treatment. There is no specific test confirmatory, which is of course apart from history and if the patient has brought the tablet and the packet, there is no particular investigation that will confirmatory tell you that it is sulfose. So whenever if you are in doubt or you have a confusing history, do not delay treatment because sulfose poisoning has a high mortality. So we have to initiate aggressive resuscitation and management. So do not wait to get a particular diagnosis that may lead to mortality. So there is a bedside test, silver nitrate test. We don't use it rapidly, like we don't use it usually. But theoretically, we take 5 ml of gastric aspirate and 15 ml of water are taken in a flask. The flask is covered with a filter paper, which has a silver nitrate, 0.1 silver nitrate impregnated filter paper. And the flask is heated at 50 degrees for 15 to 20 minutes. So if the phosphine gas is present, the filter paper will turn black. Now we come to the management part. So the main objective for the management of sulfose poisoning is resuscitation of shock and the other supportive measures. So if it's an occupational exposure or it is due to an factory or maybe it's an inhalation, so you have to remove the victim or you should transfer the victim to fresh air, open air. You have to remove him from the site of the exposure. As phosphine is absorbed through cutaneous route, decontamination of skin and eyes must be carried out thoroughly with plain water as early as possible. Again, an important point that I would make to note here is personal protective measure. We should all wear caps, gloves, mask, as the phosphine gas is toxic. So personal protective measures should be taken. Maintain ABC, airway breathing circulation. As emergency physicians, ABC is of prime importance. If airway is compromised, we should definitely go for intubation and mechanical ventilation. IV access should be taken. But since sulfose poisoning has such a high mortality and aggressive resuscitation is necessary, central line route is usually preferred. So now we come to the gastric lavage and decontamination part, which is important in case of any poisoning patient. In sulfose poisoning, we do gut contamination with 3 things: potassium permanganate, coconut oil or vegetable oil, and charcoal. So KMNO4, as you can see, it is available as these purple granules. Mechanism is it oxidizes phosphine to non-toxic phosphate. So this is the mechanism by which KMNO4 works. A small mention that I want to make here is we routinely use KMNO4 for gastric lavage and self-force poisoning. All over it is used, but there has been debate regarding its role. It is not yet clear whether it should not be given. It is not mentioned anywhere, but a lot of discussions have been going on for the use of KMNO4. Just to keep that in mind. After KMNO4, we go with vegetable or coconut oil. The mechanism is it reduces the absorption of sulfurs from the gastrointestinal system. And within up to 6 hours, coconut oil has a significant role. This is followed by charcoal. As we all know, it is a large absorptive capacity. So charcoal is going to act that way. After giving KMNO4, we give coconut oil and charcoal. We have to keep the coconut oil and charcoal in the rice tube as such. Do not aspirate after giving coconut oil or charcoal. Do not do gastric lavage with normal saline. Gastric lavage with normal saline or distilled water, unlike few other poisons, is contraindicated in aluminum phosphide poisoning, as the phosphine gas is liberated from, as soon as the aluminum phosphide is going to come in contact with water, it is going to liberate all phosphine gas, which is again the patient is going to enter into a vicious cycle. So the point to be noted in the gut decontamination part is follow the sequence of KMNO4, coconut oil, activated charcoal, but do not do gastric lavage with normal saline or distilled. Of course, the patient is usually present with hypotension. Fluid therapy, USG guided IVC remains very crucial, very important. Fluid resuscitation is very important. Antacids and proton pump blockers have symptomatic role. Vasopressors are used to keep systolic blood pressure of more than 90 mmHg. Low dose dobutamine, again, it is used as a supportive measure, not as a definitive management. 4 to 6 microgram per kg per minute is used. And some role of liquid paraffin for excretion from the gut has been established. Intensive care management. All patients of self-force poisoning require continuous invasive hemodynamic monitoring and early resuscitation with fluid and vasoactive agents. Fluid therapy should be guided by CVP, IVC diameter, or pulmonary artery wedge pressure. Inotrope should be instituted early to maintain a systolic blood pressure of more than 90 mmHg, because patients of self-force poisoning frequently go into refractory shock. For refractory hypotension and shock, IABP, it is an emerging role of IABP in mechanically supporting the heart. It also acts by decreasing afterload and improving perfusion to vital organs. Dialysis or CRRT for severe acidosis and ARF. The role has also been established. And finally, not to forget ECMO, it should be as soon as possible. It has a standard definitory role and it should be activated as soon as possible. If the facility is ECMO is possible in that facility, it should be at least for the first 24 hours, we should have, it has a definite role and we have to keep it as a standby if the patient worsens. And self-force poisoning has a very high, up to 100% mortality. So ECMO emerging and a definitive role. So role of magnesium sulfate. We will be discussing roles of few newer therapies also, but let's start with magnesium sulfate. The mechanism of action by which magnesium sulfate acts is scavenging free radicals through glutathione recovery. It's also an antiarrhythmic, membrane stabilizing effect and an effective parenteral antioxidant. The dose is 1 gram IV bolus every 6 to 8 hourly. Various doses in form of infusions have also been studied in the literature, but the bolus dose has been shown to be more effective, 1 gram IV bolus every 6 to 8 hourly. Role of sodium bicarbonate. As we have seen in the mechanism and the clinical features, metabolic acidosis is very prominent, very frequent. So in mild to moderate cases, sodium bicarbonate definitely has a role, and also as a rescue therapy in severe acidosis before dialysis. Bicarbonate level in dose of 50 to 100 milliequivalent IV every 8 hourly to maintain a bicarb level of 18 to 20 is recommended. So this is the pictorial, the flow chart is just for the general management. Suspected accidental inhalation or overexposure at workplace, you shift the victim to open air or fresh air. Ingestion, maintain ABC. Arrival to ERS, history, examination, monitoring of vitals, suspected aluminum phosphide poisoning, gut decontamination with lavage with KMNO4, charcoal, coconut oil. We have to watch for worsening of sign to system, worsening of sign and system. Usually within 48 hours, the patients usually succumb. So we have to be very vigilant. We have to do invasive and intensive monitoring, and we have to initiate the advanced intensive care management and advanced support as soon as possible. For arrhythmias, we can go for magnesium sulfate. For the refractory shock, first will be fluid therapy, vasoactive agents, and at last, not the least, IABP. For ARDS, early intubation and mechanical ventilation. For metabolic acidosis, CRRT, hemodialysis, sodium bicarbonate, and others. Now we will, of course, we will look at the role of steroids and N-acetylcysteine and other few therapies. So now let us discuss of what is new in self-force poisoning. What are the different modalities that are emerging? We will be talking about N-acetylcysteine, of course, ECMO, steroids, glucose, insulin, potassium therapy, boric acid, trimetazidine. So let's begin with N-acetylcysteine. Again, an antioxidant, stimulates glutathione synthesis and counteracts damaging the effects of free radicals by either scavenging them directly or by repairing the oxidative damage. So the dose is 150 mg per kg in 5% dextrose over 1 hour. Literature shows that the dose of 50 to 100 mg per kg is also it is protective for the liver, is improved hepatic manifestation and prevented necrosis, hepatic necrosis. This is one of the study which shows the role of NAC, and the study concluded that NAC, N-acetylcysteine, has a good role in decreasing mortality and of course incidence of mechanical ventilation. So now we come to extracorporeal membrane oxygenation, ECMO. I would like to again emphasize that ECMO is a standard therapy now that is being practiced all over for self-force poisoning. It should be initiated as soon as possible, as early as possible, in centers which are capable. In centers which are not capable, we may go for dialysis, CRRT, but ECMO has a very promising role. So we are going to discuss ECMO at a length. So it is a technique that provides temporary cardiopulmonary support by removing blood from the body, oxygenating outside the body, and returning it back to the patient's circulation. There are two types of ECMO, veno-venous ECMO and veno-arterial ECMO. Veno-venous ECMO provides respiratory support by oxygenating blood outside of the body and returning it to the venous system, while veno-arterial ECMO provides both respiratory and cardiovascular support. These are the few articles for which shows the efficacy of ECMO in aluminum phosphide poisoning. Successful treatment has been seen in aluminum phosphide poisoning with ECMO. As you can see, there are so many case reports from Nepal and Iran which show that it's a ray of hope in upcoming time that patient self-force poisoning mortality will be decreased by ECMO. So how does what is the role of ECMO and how does it help in self-force poisoning? So there are 4 potential mechanisms. First, as we all know, self-force poisoning causes severe respiratory and cardiovascular complication in form of ARDS, pulmonary edema, hypotension, and shock. ECMO provides advanced respiratory and circulatory support, which helps to alleviate this complication and improve oxygenation and ventilation in the lung. ECMO also helps in correction of metabolic acidosis by improving oxygen delivery and carbon dioxide removal, which can lead to improved tissue perfusion and reduce lactate accumulation. Other mechanism is that, as we all know, self-force causes cardiac toxicity. So ECMO has been seen to help reduce workload on the heart, improve cardiac output, perfusion, myocardial function, and blood pressure. Finally, it potentially helps to remove the circulating toxins such as phosphine gas, which is the primary toxic metabolite of aluminum phosphide. By removing these toxins, ECMO may reduce the severity and progression of self-force poisoning and improve patients' outcome. So to summarize, of course, I would just like to mention 2, veno-arterial and veno-venous. Veno-arterial referred in patient with concurrent both cardiogenic and respiratory manifestation, and veno-venous is prepared in patients with isolated respiratory failure who have toxin-induced ARDS, while stable hemodynamically, who are unresponsive to high ventilatory support. They can be managed very well with veno-venous ECMO till recovery of gas exchange occurs. These are certain prognostic factors. For example, if the patient is showing refractory shock, hypotension, arrhythmia, ejection fraction less than 20%, bicarb less than 12, pH less than 7.5, which means acidosis, all of these are red flags, or maybe indicators that we have to put the patient on ECMO. It has to be started as early as possible. But if we see worsening clinically or any of these are present, we should shift the patient to ECMO. So to summarize, the benefits of ECMO are respiratory support, cardiovascular support, correction of acidosis, and removal of toxin. The take-home message is definitive role of ECMO, and it should be started as soon as possible. Role of steroids. They have been used to combat shock. The role of it is controversial and is just used as a supportive measure as of now. Another therapy is glucose, insulin, potassium. The main concept is we give insulin as high dose infusion, maintain potassium between 3.5 to 5, and we give glucose 50% dextrose. And the therapy basically works by increasing the metabolism of lactate and limiting the metabolic acidosis. Insulin infusion also improves ionotropy of the heart and reverses acidosis by increasing myocardial carbohydrate uptake and utilization. There are various studies which have used high dose insulin as infusion, hypertonic dextrose 50%, potassium, all these three as a therapy. And several other studies have also showed that it improves the survival rate and decreases deaths. As I showed earlier also, the packet also of the Cellforce has written that you may use IV intravenous hypertonic dextrose. So again, which this GIK therapy is also promising for the future. The role of trimetazidine, not very much studied, increases ATP, it's cardioprotective, anti-ischemic drug, and decreases intracellular calcium. Role of boric acid, still experimental, but it's just, it has been postulated that boric acid can help by trapping the phosphine and neutralizing phosphine, as it is a Lewis acid, and it will enhance its excretion. There are other miscellaneous therapies which are under investigation, which might come later on in form of IV lipid emulsion, digoxin, vitamin C, vitamin E, melatonin, glutathione, beta-carotene. All these have been proposed for the treatment, but their efficacy requires more research. So the poor prognostic indicators for Cellforce poisoning, if we see overall, are hyperglycemia, metabolic acidosis, refractory hypotension, shock, AKI. What are the take-home messages? High mortality, no available antidote, aggressive resuscitation and monitoring, role of newer supportive measure like Maxulf, sodium bicarbonate, N-acetylcysteine, and emerging role of ECMO as a standard therapy. So this is just a call center at AIIMS. There's a toll-free number which is given, which gives information about the various drugs and poisons, just for information. So at the end, I would just like to sum up by saying that as time is very crucial in management of patients presenting with Cellforce poisoning, the role of emergency physician, doctors, intensivists becomes very important and critical, as Cellforce poisoning has high mortality rate, and initial aggressive resuscitation and prompt management is of vital importance to save the life of the patient. Right, I would like to conclude my presentation with that.
Yeah, thank you, Dr. Rajvi. So undoubtedly, it was a wonderful presentation. Almost you touched each and every aspect of aluminum phosphate poisoning. So in that, there are many advances, kind of future trends like N-acetylcysteine, ECMO, GIK, steroids, trimetazidine, and boric acid. So regarding NAC, we used to, when we were doing our MD, we used to practice this thing, N-acetylcysteine, in GIK sometimes, but not for aluminum phosphate. We used to follow for Takotsubo cardiomyopathy, secondary to the hanging. In such cases, we used to practice GIK and all. So that is one thing. Then trimetazidine, boric acid. As you said, still it is debatable. It takes so you have to go a little bit further to discuss upon this. Then miscellaneous like vitamin C, E, glutathione. There are centers where they are using glutathione. Still, certain centers they are practicing, they are using glutathione. So finally, it was a wonderful session. Thank you so much for enlightening on it. So can we take up some questions if you are there any?
Sure, sir.
I think so far no questions. Then, so what about your experience and in treating aluminum phosphate poisoning patients?
So what I would like to emphasize again is that I think as soon as we see a patient of sulfurous poisoning or we have a slightest of doubt, we have to be aggressive and careful and vigilant from the first moment itself. We have to keep at the back of our mind that patient is going to deteriorate. 90% of the patients sulfurous poisoning that we have seen usually deteriorate within 48 maximum to 72 hours. So in that cases, those who have those hospitals which have ECMO equipped facility, they should activate the ECMO therapy as early as possible so that the patient can be taken as early as possible on ECMO. So that is one of the most important thing, and the role of ECMO has been like all the literature shows that it is a very promising and a definitive role.
Yeah.
We just have to, the one thing that we have to keep in mind that there is no specific antidote, we have to try whatever and as much that can be done.
So there is a question, Rasi. Coconut oil used at which dose, ma'am?
Yeah, there is no particular dose of coconut oil. We usually get that bottle of coconut oil and we instill it into the RT. There is no specific dose in the literature at 10 ml or 5 ml. The main mechanism is going to increasing the absorption in the lining of the gut. It's going to protective surface. So I think
there is no particular dose as
no particular dose that 10 ml, 15 ml.
Actually, when we are doing our MD, we used to practice differently. We used to mix up that multi-dose active charcoal with coconut oil to prepare a slime. So for that, there is no particular.
That is a great idea for not mixing charcoal with water. So that will again protect from water.
Yeah, that's we should not mix it up with water. If you
mix it up with water, charcoal.
When aluminum phosphide get in touch with water, phosphine gas will be more. That's why we used to prepare slime with coconut oil instead of water. So for this question, I think there is no fixed dose for it. Just to make it just to prepare a slime, that's it. Sometimes it may take 10 ml, 20 ml, 30, it doesn't matter. It doesn't matter more, it does not cause any harm to the patient.
Exactly.
Exactly. So then one more thing I'd like to ask you here. What about dialysis, early dialysis in aluminum phosphide poisoning?
So basically, if we do not have the facility of ECMO or CRT, we have whatever we have in our hands, even if it is dialysis, we have to go for it.
Yeah, so in majority of the centers, we don't have ECMO facility and all. If it is there, also very difficult to take care of all the logistics and all. So I think dialysis. I think aluminum phosphide dialysable isn't right. I think it is.
Yes, dialysis will help, but for those facilities who have ECMO or those hospitals which do, they just maybe they can keep that in mind that it has a role.
Then regarding role of steroids.
So it is highly controversial.
Highly means
we don't use it. We don't use it, but maybe.
We don't use it all. Yes. So there is no point of using steroids for aluminum phosphide poisoning.
That was just for a discussion that everything should be covered. There should not be anything which is left.
Good. So really, it is a wonderful session, Dr. Rajvi. So happy to interact with you.
I would just like to thank the whole staff of Yashoda Hospitals and Srinath sir and even you for moderating the session and giving this opportunity.
Naveen sir.
Yes.
So any inputs from your end?
This is actually, I've never dealt with any of these patients before. So no first-hand experience as such. But that gastric lavage point is quite interesting. So there are some things even in cyanide poisoning and also we say inhalational toxicity can occur.
Yes, sir.
Actually, so thanks for highlighting that.
We have seen, I think, more than hundreds of cases when you are doing our MD in Vinayaka Missions, Tamil Nadu. So that is the Center for Excellence.
Sir, anything that I have missed and you want to add?
No. You touched each and every aspect of aluminum phosphide poisoning. So actually, I was thinking in terms of what is in certain areas like decontamination techniques using coconut oil, advantage of using coconut oil, then like NaCl cysteine, then certain things like glutathione. You touched in each and every aspect of it. But so I think no questions. Okay. So I'd like to thank Dr. Srinath sir for creating such a wonderful platform for each and every emergency physician and resident in this country and across world as well. Then I will thank Dr. Naveen sir for organizing everything. Then I will thank our semi-board and envoy so for giving this kind of opportunity to encourage our younger generations, then to encourage our new people and to impart and inculcate knowledge among ourselves. I thank you and all. Last but not the least, all our spectators and viewers. I thank all the people, those who joined for today's session. Thank you and all.
Thank you, sir.
Pawan?